Hi, this is Brian Kim. I'm going to share with you this case where I had an anterior capsule radial tear, how I handled it, how it happened, and the techniques that I'm able to employ to minimize any capsular trauma, being able to chop the lens, disassemble the lens without applying any force on the capsular bag, no torsional stress on the zonules or the bag. I was essentially able to do this case as a routine case without causing any worsening of the capsular tear. I'm able to prevent propagation of the anterior capsule tear to a posterior capsule tear and minimize complications. So I'm going to begin my puncture style capsulorhexis. I make a puncture with my forceps, pull down. You can see that the capsule tear didn't come towards me, it went a little bit to the left. And so I'm trying to grab the edge of it and I'm kind of going around. I'm trying to keep the rhexis centered and sized over my corneal markings, trying to be very careful here. As I re-grab subincisionally and I turn the corner, you can see that the capsulorhexis just runs right out. It didn't even go very slowly, it just went really rapidly out. So what happened? I'm going to show this step again in slow motion. A couple of observations. Number one, I had quite a bit of viscoelastic egress during all this manipulation. So if you go back again, you can see there's quite a bit of viscoelastic egress. Number two, I believe this patient had quite a bit of posterior pressure. And normally posterior pressure is not really a big factor when I do cataract surgery, but clearly in this case, I did not recognize how much viscoelastic came out and how much posterior pressure this patient had. And once I turned the corner, the rhexis just went straight out. So what do you do at this point? So I come out and I try to reevaluate here. You can see the pupil came down quite a bit as well. Again, this is a sign that this patient had significant viscoelastic egress, but this patient also has a kind of an unusual anterior chamber, and you'll see that as the case progresses. So I fill the eye with more viscoelastic. I'm trying to grab the rhexis edge, and I try to do the little maneuver. I'm going to try to pull back. But, you know, as I'm pulling back, I can see all of these folds in the rhexis. And so I don't believe I can salvage the rhexis. I do not believe the little maneuver is going to be able to work in this case. And you look at this pupil. The pupils come down quite a bit. It's just a little bit of a strange eye. The chamber is not quite stable. You can see again that that means that the chamber is collapsing, and that's why the pupil came down. So I do think this patient had quite a bit of posterior pressure. In this case, I think a Hohn balloon in retrospect could have been helpful. I don't put a Hohn balloon routinely, but I probably will do that for the second eye. So I use some long Van-Ness scissors after I fill the eye with viscoelastic, and then I'm going on the other side to complete the capsulorhexis. I grab it with the forceps, and then I'm going around circumferentially, and I'm finishing off the second half of the rhexis. So obviously I have an anterior capsular tear to the right of me. And how am I going to do the case? Well, I'm going to do this case as I routinely do. And why is that? Because in my routine technique, I don't have to worry about any significant zonular or capsular stress. So I'm doing my capsular fornix hydrodissection technique. I place a cannula out to the equator contra-incisionally. I point the tip down and I get a nice fluid wave, but I did not do a very aggressive fluid wave because of the capsular tear. I decompress to the left side and then very gently I'm able to turn the lens on the right side. So now I begin the phaco. I irrigate the surface of the eye, lift the incision with the chopper with irrigation off, enter to minimize Descemet's trauma, and then remove the surface epinuchal material, place a chopper out to the equator, place the phaco tip vertically, subincisionally, crush the lens material, and this is the double chop maneuver. I place the chopper out contra-incisional over the right heminucleus. I pull the chopper centrally toward the phaco tip, and then I was able to crush the right heminucleus in half. I prolapse the first quadrant up out of the bag, and I'm mechanically fracturing the pieces so that they are emulsified. I prolapse the second quadrant out of the bag as well, and I'm crushing the lens pieces between the chopper and the phaco tip, utilizing primarily vacuum in this case with minimal ultrasonic energy. Because all of the lens disassembly occurs within the endonuclear space, I'm able to crush the lens pieces, not needing to rotate the lens, and this helps minimize any capsular stress or zonular stress, and this definitely reduces the risk of propagation of the anterior capsular tear. I'm rotating the second heminucleus in front of me, placing the chopper out to the equator, placing the phaco tip deep, sandwiching and crushing the second heminucleus in half. This mobilizes the third quadrant, and I'm able to crush that third quadrant into smaller bite-sized pieces between the chopper and the phaco tip. And now I'm in the last quadrant. I'm placing the chopper out to the equator and then crushing that last quadrant between the chopper and the phaco tip, crushing the lens pieces and creating smaller bite-sized pieces. I'm primarily using vacuum in this case and minimal ultrasonic energy due to the softness of the lens. I then carefully remove the epinuclear material using the phaco. I want to make sure I stay clear of the right side where there's that anterior capsular tear. And so I'm able to prolapse the endonuclear material and the epinuclear material out of the bag. I push BSS, take the phaco tip out, and then switch to the INA. And this is my way of trying to maintain chamber stability. I begin my INA subincisionally, removing the cortical material from the subincisional space first, and then removing the cortical material from the left side. I'm going to approach the right side and remove the cortical material in the area of the anterior capsular tear last. So very carefully, using foot pedal modulation, I'm using the vacuum to carefully remove the cortical material. I'm in the subincisional space, very carefully making sure I'm able to get as much of that cortical material out using the INA. And then very carefully, you could see just very gingerly, I'm removing that cortical material again, grabbing it along the anterior capsule edge. I'm making sure I'm not grabbing the capsule in the process. And I'm just gently going underneath the anterior capsule, making sure there's no residual cortical material left. I switch to the polish mode and very carefully and gingerly I'm polishing the posterior capsular surface. I'm confident that the radial tear did not propagate posteriorly, so I'm able to polish the posterior capsule very nicely. I'm then going around underneath the anterior capsular rexus edge, removing any potential cortical material and lens epithelial cells. I'm making sure I stay away from the anterior capsular tear when I'm polishing underneath the anterior capsular rexus edge. In this case, I don't do an aggressive capsular flush because of the anterior capsular tear. And so as a result, I'm going to inject my cohesive viscoelastic into the bag, but I make sure I do not overfill the bag because this can propagate the anterior capsular tear. I'm just filling up the bag gingerly and then filling the anterior chamber as well. I'm injecting my single piece acrylic intraocular lens into the capsular bag, and I'm going to make sure that the haptics are going to be oriented perpendicular to that anterior capsular tear. I'm using the cannula here in this case to tease off the leading haptic and then the trailing haptic. And as I push the trailing haptic down, I'm making sure that that trailing haptic goes underneath the anterior capsular rexus edge. And I'm rotating that lens slightly, again, so that the haptics are oriented 90 degrees to the anterior capsular tear. This patient has glaucoma, and so at this point, I'm going to perform the eye stent. I filled the eye with dispersive viscoelastic. I'm placing the gonio lens on the eye. You can see there was quite a bit of viscoelastic between the gonio lens and the cornea, and this helps maintain a very clear view. So the technique is very straightforward with the eye stent. You want to stab, and then you want to flatten out. You can see my hand rotating, flat, 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 and then I'm trying to advance. Sometimes you'll get stuck, and you'll encounter the scleral wall, and so sometimes you have to reposition it and then continue to slide, and you can see that this eye stent slid very nicely into place. I like to ensure that the eye stent is in excellent position, and what I like to do is inject some dispersive viscoelastic while the gonio lens is in place, and that clears out the blood and the pigment, and I'm able to just tease it with the cannula tip, strum the eye stent to make sure it stays in good position, and then I come out. I go in with irrigation off and then begin. As I remove the viscoelastic, I'm not going to go underneath the lens like I normally do. And because of this, you have to be very careful because the lens can suddenly jolt or move as the viscoelastic that's trapped underneath the lens may pop out. And you want to make sure the haptics don't suddenly move position as well, because you need those haptics perpendicular to the rent. So you can see here, I'm tapping on the lens and suddenly the lens jerks. So let's see that in slow motion. I'm tapping on the lens and it suddenly jerks. And the key is, as you tap, you want to apply some gentle posterior pressure on the lens so it doesn't jiggle too much. And so I was able to tap it back, and you can see that the haptics did not move. And so again, the haptics are oriented perpendicular to the anterior capsular tear. I push BSS in the eye as I come out to maintain some chamber stability, and I hydrate my incisions. So you can see I had an anterior capsular tear, which radialized. The little maneuver could not salvage this one. I had to recut my rhexis. I did gentle hydrodissection, which worked fine. I did my standard double chop, cross chop, mechanical fracturing forces. Because all of the forces are directed towards the center, I was able to mobilize and crush and remove and evacuate the lens material very easily and safely. I was able to orient the haptics perpendicular to the rent. Despite the posterior pressure and the anterior capsule radialization, this ended up being like a routine case, and this patient did very well. I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.